Hello guys, today I'm going to discuss few of the question of INI set May 2026 Pathology Recall. So the first question is, a patient present with fatigue, HB of 8, MCB of 68 and low serum ferritin. Likely diagnosis. So the patient is presented with the fatigue and HB of 8. That is, patient is anemic. MCV is 68, that is low. Normal MCV is ranging from 80 to 100. MCV is low, so the patient has microcytic hypochromic anemia. As we know the causes of the microcytic hypochromic anemia, we have one mnemonic that is CETA. S for sideroblastic anemia, I for iron deficiency anemia, T for thalassemia, and A for anemia of chronic disease. In this anemia of chronic disease, present more as normocytic normochromic anemia rather than the iron deficiency. So we have option iron deficiency anemia, megaloblastic anemia, sideroblastic anemia, and anemia of chronic disease. So option number B is out, and it is megaloblastic anemia, but the patient has microcytic hypochromic anemia. So now we have three options, that is iron deficiency anemia, sideroblastic anemia, and anemia of chronic disease. In addition to this, patient has low serum ferritin, which is seen in iron deficiency anemia. So the answer of this question is iron deficiency anemia. As we know, the iron is stored in our body majorly in the form of ferritin, and few of amount is stored as hemocyte. In iron deficiency anemia, there is low iron, so body utilizes this stored iron for the synthesis of hemoglobin. So there is low storage iron, that is low serum ferritin in iron deficiency anemia. Second question is, liver biopsy of an alcoholic patient suspected of cirrhosis is as follows. What is likely state? So patient is alcoholic and suspected of cirrhosis. As we know, in cirrhosis there is diffuse fibrosis of the liver. There is formation of regeneration nodules. So they have asked for the stain. They have given options: Gimsa, PAS, Masson's trichome, and Jaden stain. They have provided a picture. As we can see in the picture, there is red color and there is blue color, we can see. So we can appreciate the formation of nodules, and there is bridging fibrous septa that is highlighted by the blue color. So Gimsa, it gives the dark blue color and it stains the cells. We used to stain the cells in the hematology by the Gimsa. PS is used to stain the mucin, basement membrane, the capsule of different various fungus, and it gives magenta pink color. Jaden stain we used to stain the acid fast bacilli like Mycobacterium tuberculosis, and it gives the bacilli the reddish color and in a background of bluish green background. Now remaining is Masson's trichome stain. So Masson's trichrome is there, it gives three colors. It is used to stain the collagen fibers. As we can see in this pic, there is fibrosis, blue collagen fibers are stained. So this is a Masson's trichome stain, which gives three color, that is collagen are stained their blue color, cells are red, nuclei is a dark blue purple nuclei. So this is Masson's trichome stain, which is used to stain the collagen fibers. Next question is, histopathological examination of a biopsy from the gastroesophageal junction is shown. What is the most likely diagnosis? As we know, the lining of esophagus is normal lining of esophagus is stratified squamous epithelium, And the gastric epithelium has surface mucus cells. So they have asked for most likely diagnosis. Option are adenocarcinoma, Barrett esophagus, low-grade dysplasia, and squamous cell carcinoma. We can see the presence of goblet cells here, columnar lining, goblet cells. So goblet cells are usually found in the intestine. We can't see goblet cell in the gastroesophageal junction. So these goblet cells columnar lining is replacing the esophageal lining, that is stratified squamous epithelial lining. So normally we don't have to see this lining. So there is metaplasia. So this is answer of this question is Barrett esophagus. It can't be adenocarcinoma because in adenocarcinoma there should be glands, that this plastic gland should be there. And in low grade dysplasia, these don't have low grade dysplasia, and low grade dysplasia they usually will not give because it is very minute change. Squamous cell carcinoma, there's no squamous cell carcinoma because for squamous cell carcinoma there should be atypia, there should be invasion. So it is Barrett esophagus, and we can clearly see from picture there's presence of goblet cells, columnar lining, and it should be in the intestine, but it is present in the gastroesophageal junction, which is abnormal. So the answer of this question is Barrett esophagus. Next question is, which amyloid protein is classically associated with secondary amyloidosis occurring in the chronic inflammatory conditions? As we know from the knowledge of amyloidosis, there are basically three type of amyloid, that is AL type, AA type, and ATTR type. There are so many amyloid types, but basically these are the three. So AL amyloid is seen in the condition like multiple myeloma. There is increased light chain productions. A beta is seen in brain, like Alzheimer's disease. ATTR is seen in familial amyloidopic neuropathies or senile amyloidosis. Now the remaining option is AA amyloid, which is seen in the chronic inflammatory condition, because in the chronic inflammatory condition, there is macrophage activation and there is stimulation of the liver for the production of SAA, that is acute phase reactant, which further aggregate to form the AA amyloid. Yes, we can see from this slide, primary amyloidosis is AL, secondary is reactive, also known as reactive, that is AA. Seen is chronic inflammatory condition like rheumatoid arthritis, tuberculosis, osteomyelitis, can be associated with few solid carcinomas, and there are other type of amyloidosis like ATTR is associated with familial amyloidotic neuropathies, systemic senile amyloidosis, and A beta is seen in Alzheimer's disease. And this is the pathogenesis of the amyloidosis. We can see the AL protein formation. There is acquired mutations. There is monoclonal B lymphocyte proliferation, as in multiple myeloma. And in chronic condition, there is macrophage activation. These stimulate product produce the interleukin 1 and 6, which further stimulates liver to produce SSA protein, which is acute phase reactant. Or this due to the excessive production of the SSA protein, there is limited proteolysis of this protein, and this accumulates as a AA protein. So in chronic inflammation, there is AA amyloidosis.